All right, here we go.
All right.
How's it going?
Good. Episode 1?
Episode 1.
All right. So I think we talked about it. We're going over a lot of topics on what to talk about. And I think the best one, like we said, was to go ahead and do non-operative management of arthritis.
Arthritis, knee arthritis specifically, right?
Yeah, I'm with you.
Yeah, so a patient comes in, basically maybe they don't even know they've had or been diagnosed with arthritis. They come in, they're having knee pain, you get an x-ray, and that x-ray shows, moderate arthritis. They're not bone on bone. Mm-hmm. They're a patient who is your typical kind of 50, 60-year-old that their knees just progressively getting worse. Sometimes they have an injury. But they have enough arthritis where you talk about, okay, what are our options? And so one of the big things that I think about, that I always talk to people about, is, injections. I think that's probably a hot topic with regards to non-operative treatment specifically. And I'll name a few and then get your opinion. I think steroid is a good first line, decreases inflammation. I've got patients, we do a steroid injection, they don't come back for a year.
Yeah.
They get a lot of relief. Other patients, it's maybe a few months. But the goal is that you're decreasing that initial amount of inflammation, and then you can come back and try something like a hyaluronic acid injection, which we can get into more detail about. But what's your typical first line for tritions if you were going to talk about a non-operative approach there?
Yeah, that's usually mine. Usually the steroid. I'm a triamcinolone guy. I think it sticks around a little bit longer. Mm-hmm. And that's how I used to do it. I mean, in some ways, we're getting kind of pushed by insurance on it. And it's kind of what they prefer to be first line. But it was what I was doing anyway. It's kind of what I would do even if they weren't pushing us. And like I said, we talked about the controversy of HA and stuff like that. But it works well. I'm with you. I see people get better. And sometimes, so for some people, it's the best option out of all the injections. It seems to give you the best results. How frequently would you do them?
Typically for steroid injections, I only go every 3 to 4 months.
Yeah.
Try not to do it more frequently than that unless it's some certain indications. Specifically like frozen shoulder, I might go once a month for 3 months.
Yeah. But
really, on the whole, I try to do every 3 to 4. If a patient comes back and they've had 2 injections in a 6-month period of time, maybe it's not, they've had one and we do another one at 2 months, I make them wait 6 months before they're able to have the other.
Gotcha.
So I kind of use that. I don't know, do you go more frequent than that?
No, I mean, I've kind of gone the other way. I've gone like 6 months for steroids, and I try to make them, if they are having problems in between that's kind of where I'll throw the HA in.
Gotcha.
There was, I think it was about a year or 2 years ago, there was a saline versus steroid MRI study that looked at cartilage thickness, and I think it was 4 injections a year for 2 years. So the steroids had significantly more cartilage loss.
You can see more degradation.
Yeah.
And I think that's don't you agree that's the big thing? Like that's the major deterrent for frequent, like whether you're doing shoulder, you're doing knee, you're doing hip, is that you worry about joint degradation, soft tissue damage. Yeah. And so, no, I completely agree. And I mean, really, 3 to 4 months would be probably my preference.
Yeah.
Every once in a while, people come in. But, going back to the HA, so the hyaluronic acid, the viscosupplementation, everybody calls them the rooster comb injections based off of the initial isolate from the comb of a rooster. But I feel like more patients come in and have heard about it from other people. Yeah. And hey, in a good way, tell me about this. And so in some cases, I feel like anecdotal evidence from other patients and things that people have heard, they come in and they're asking for that.
Right.
And they're kind of disappointed if I mention, well, let's try a steroid first.
Yeah.
do you see the same thing with people?
I do. And it's just, steroids been around so long that I think that the HA is still in this new category, right? It's kind of in the anterior hip category of newness, that it's like, oh, well, this is newer, therefore it should be better. And I think, most people know, newer doesn't necessarily means better. And exactly. I think in a lot of situations I tell them, research-wise, they're, big studies pretty close in their efficacy for treatment. what I didn't see in the pictures, I mean, in the papers that I see more in my clinical practice is that some people do better with the HA, some people do better with the steroid.
Right.
So people come in, I go, well, if you hadn't had a steroid before, you might be a steroid person.
Right.
You know, and I'm not sure there's any evidence behind that, but that's the stuff that's hard to, and that's kind of what I see anecdotally. I'm not sure if you see the same thing.
No, I see the same, and it's interesting because you'll do, what I typically do is I start with a steroid, and I give the patient, I say, look, we're going to start here. And I talk to them about viscose supplementation and say, okay, in 4 to 6 weeks, if you're still having a little residual pain, then we can come back and try hyaluronic acid. And so we'll go through a round of that. And usually I'll try to do the 3 injection series as my preference. I feel like doing the 1 injection options, it's not that people do bad with it, it's just that I've seen more pain with that.
Yes. Just
from the amount of fluid that you're putting in there. I think patients sometimes don't respond as well. But they'll come back, and after a round of that, I've got patients that come back and say, hey, you know what, I think I did better with steroid.
Yeah.
And we don't ever do the hyaluronic acid again.
Yeah.
Some patients, though, and this is kind of the pattern I get them on, is I try to spread things out every 3 months. So I'll try to do a steroid, and after we get kind of going with things, I try to wait 3 months to do the hyaluronic acid or the gel injections, and then have them 3 months later, they can do another steroid.
Yeah.
So you're spreading your steroid out every 6 months. You're spreading your hyaluronic acid out every 6 months. And that's kind of what I do, especially with elderly patients who are not operative candidates. I'm like, okay, you have a horrible knee, but the only thing I can offer you, short of therapy and activity modifications and things that they're doing already, is we could try these injections.
Yeah.
As long as they're healthy enough to have steroid, they're not diabetic, they don't have anything else, that's the pattern I get. Every 3 months I do that kind of algorithm we were talking about. And people seem to do pretty well, and they're actually satisfied with the fact that, hey, I know in 3 months I can go in, I have an option of, because no one gets complete relief when they have that advanced arthritic, picture. But how do you use, because I know you use PRP probably a lot more than I have, but where do you use PRP in a setting like this? Like, how do you throw that in?
So I try to give at least kind of hint at it for people, but I usually kind of tease with it first. Be like, hey, these are kind of like, this is the spiel, and I like that 3 month interval kind of that you alternate with, and then tell them there's another shot. There's actually 2 more shots that are not covered by insurance, and then I usually kind of feel out where they are on that part. Because
so that's PRP and stem cell?
Right, and for most of them they say, let's just do the ones with my insurance. So those work pretty well. They work very well. Okay. Like, let's stick with that. But there is that group of people who's like, well, tell me more. I want to know the full picture. So it's kind of like gauging how much they want to know about it. And when they do, then I kind of explain to them, hey, there's a pretty good study about 2 years ago out of Rush in Chicago, HA versus PRP, and statistically significant numbers in favor of the PRP.
Right.
And that most people who I do give them to have already tried the other 2.
And in that study, so I can't remember with regards to that PRP selection, did they do a leukocyte rich or leukocyte poor? Did they specify?
It was leukocyte poor.
Okay.
And I think he was finishing up some of it when I saw him. I think they were doing the ACP system.
Because isn't that the big thing now with the PRP systems is there's been some things with regards to the preparation. Even the PRP can vary. And so which camp do you fall in when you do it? Are you doing more of the...
For OA, I'm a leukocyte poor guy.
Okay.
I think that we know that white cells are what's generating a lot of this problem, the IL-1, the IL-6.
So get the inflammatory stuff out.
And I just want that out. I actually want the opposite. What I'm really looking for in those alpha granules in the platelets is the IL receptor 1 antagonist protein. It's like a big mouthful.
Yeah, so get the inflammatory stuff out, give the anti-inflammatory
stuff through the platelets. There's a little variability. So people used to think that this 7 times concentration was kind of the sweet spot. The ACP is a little bit lower than that. But then clinically, that's the one that a lot of people are using because it's in all honesty, it's a little easier of a preparation, and it's pretty consistent on what you get. So, but even then, I think everybody who's done these knows that they don't work every time. If they worked every time, they'd be a rocket ship, and everybody would be using them. And sometimes you don't get anything out of them.
So when you're the patient comes in and let's say you did a steroid injection, maybe you did a hyaluronic acid injection, but you get to the point where you've decided, okay, we're going to try a PRP.
Yeah.
How far out from a steroid would you wait to do it? How long do you have them hold, like NSAIDs? Like, so what's your protocol around when you're having somebody come in for that?
Yeah, so I try to couple with therapy too.
Okay.
So if I'm going to do a PRP, I usually recommend therapy, and there's a PRP protocol.
Okay.
That I have a therapist work with them on when to get them back to activity. Because I'm like, if you're going to invest in all this, let's
we want to make sure that you're
let's make it get some bang for our buck.
Sure.
Out of it. So let's do the therapy. Most of the time, for most PRP formations I do, I'm usually keep it pretty light for 2 weeks.
Okay.
After is kind of my window, and even then, that 2 weeks is a no NSAID.
Okay, so 2 weeks hold NSAIDs.
Yeah, and that's not like that's
well,
like
I've
my
heard,
protocol.
like, so when I've done some PRP, especially for elbows and other places, like I usually will wait a little bit longer on 4 weeks, but I don't know that I've seen any literature to say the hard rule. I mean, you're basically trying to allow those natural factors to begin to work, and you don't want to throw in a medication that's going to block that.
Right, and for me, they should be pretty pain-free at 2 weeks. I know that sounds like it was just at rest, not doing activities.
Right.
So if we give you a shot of PRP and at 2 weeks, just my experience, you're still hurting a lot.
Yeah.
Like, I haven't seen anybody all of a sudden turn the corner at 3-4 weeks.
Right. You know that you can tell very quickly.
So it ends up being at that 2 week mark. I mean, I hope that they're not needing anti-inflammatories.
So aside from the PRP, you'd mentioned stem cells.
Right.
And I know that's a deep dive, but so you get that patient, and the thing, I think the reason that I probably haven't jumped into the stem cell stuff as much is because of the cost.
Yeah.
Because I haven't had as many patients because it's not covered by insurance. But in those patients that you've had a chance to use that on, have you done that more in the setting of going in and scoping the knee and doing it at the time of surgery, or are you doing it more in an outpatient setting in clinic?
Mostly in surgery. There's a couple reasons. One is the cost.
Right.
And the other part is that the stem cell that I do is a bone marrow aspirate. It's got the best safety record, I think. If there's research on it that is legitimate, it's
safe.
Safe.
Painful to try to do in clinic.
Yeah, I mean, I know a couple people who've done it, and they swear that it wasn't that bad, but you just, it's not I'm not trying to talk people into getting their pelvis aspirated from the bone marrow while they're awake. So most of them do when they're asleep, and if I'm going to have to put them to sleep, then I'm saying, well, let's do the little things that might be controversial on a knee arthroscopy where you're doing a debridement and taking care of the loose flaps and doing like a nice chondroplasty.
Right.
Like let's kind of
clean up.
Yeah, like a little silk purse right procedure. Like kind of get everything nice and cleaned up and then put the stem cells in there. And I think that it just asks less of the stem cell, right? The stem cell's not going to mechanically, smooth off a big loose lesion and stuff like that. I think that the combination of that, I've had some success. But most of the people who come to see me about it, who end up pulling the trigger, have already know they want it. So they've seen somebody else who said, oh, well, hey, if you really want it, go talk to this guy.
Yeah.
And then I'll get them in, and they're like, well, and they've checked all the boxes in their head. And
that's been the handful, and I have not done many, have been patients that have actually come in requesting it and talking about it. And I kind of follow the same protocol post-op with regards to similar to what we were talking about with PRP. Do you change much after? Okay, so follow the same thing.
Follow the same thing.
Okay.
And I don't think there's any. We just don't know enough about all that stuff. I think for there to be a big body of evidence to say, hey, this is wrong, this is right on what you do after.
Right.
But
I think there's options though. I think those people need to realize is that the injection options. I think patients do really well. I don't feel like everyone has to jump into a total knee replacement.
No, and I'm sure you've seen the same thing. Somebody comes in, they do one steroid shot, and then they saw somebody who says, you need your knee replaced. And that's, at least my perspective, I tell somebody it's not a need thing.
Right.
It's like...
Well, and every patient's different.
Right.
I've got some that come in, and I had someone just recently, they came in, and I hadn't seen them in 2 years. They said steroid injection gave them relief for 2 years. Yeah. That's all they wanted was another steroid injection. Yeah. I was like, wow.
Yeah.
So, but I think there's definitely options on the injection side. So we'll have to pick up on our next topic. Maybe we can talk more about surgical treatment or even therapy guided stuff toward.
I think, and then for me, that I think everybody asks me, because I don't do knee replacements, is like when is it time to do it, and that's and when do you want me to get people over to you? So maybe next time we can talk about
just kind of when people are ready.
When's the total knee time?
Yeah, that sounds good.
All right.
Sign off.
Episode 1.
Good job.